Welcome to the New York City Bar Association podcast. Opinions expressed are those of the speakers and not necessarily of the city bar.
I'm Zimmerman, and today's podcast is about informed consent to the use of AI in healthcare settings. I'm a lecturer in AI and ethics at Columbia University's Masters of Bioethics program, where I also run a Bioethics Journal. And today I'm here in my capacity as the co-chair of the AI in Healthcare Subcommittee of the New York City Bar Association's Task Force on Artificial Intelligence and Digital Technology. And today our guests are Alex John London and Susannah Rose. Alex is the K&L Gates Professor of Ethics and Computational Technologies and Chief Ethicist at the Block Center for Technology and Society at Carnegie Mellon University.
Hi, thanks for having me. It's a pleasure to be here.
Thank you. And Susannah Rose is the Vice Chair of the Artificial Intelligence Committee and the Executive Director of the AI Discovery and Vigilance to Accelerate Innovation and Clinical Excellence, the Advance Center at Vanderbilt University Medical Center, where she's an associate professor. She is a member of the core faculty at the Center for Biomedical Ethics and Society.
Great. Thank you for having us.
Thank you both for being here. We really appreciate your taking the time to share your expertise. So informed consent is the cornerstone of patients' rights in many ways, and it's really crucial to both the legal and ethical frameworks for healthcare. It allows consumers, healthcare consumers, patients to make fully informed voluntary decisions about medical interventions. This episode really explores the ethical requirements of informed consent as it applies to AI. Both guests today are bioethicists and operate in the bioethics space as non-lawyers. And we think that perspective is really helpful in fleshing out the ethical issues. So AI tools are used in a lot of capacities in healthcare. So please feel free to just use examples as we go, as we talk about the different issues, so our guests can really understand what we mean. There's a lot of uncertainty about informed consent to the use of AI and about when it is necessary and when maybe it isn't necessary or isn't quite relevant or even isn't quite satisfactory or enough. So to you both, what are the ethical reasons to require informed consent to medical care generally, and how do they apply to AI?
So as an ethicist too, I've worked both within the clinical setting and the research setting and the operational setting. And the importance of informed consent is quite central to American healthcare delivery. And with regard to artificial intelligence, while it is a unique and new opportunity and a new technology, actually quite a few technologies, because it's not just one, we also need to think about how it fits within the healthcare setting. I don't think that AI is particularly unique in the sense that it needs its own structure or ethical informed consent within a healthcare system. Like many new transformational technologies, we have to use the same structures that we currently have while adopting them and making sure that we understand them in order to talk to our patients, how we're using them effectively, and ensuring that they're governed properly within our healthcare systems.
And Alex, do you want to chime in?
Sure. I think the moral work of informed consent is to transform something that might otherwise be illegal or impermissible into something that's morally permissible. So to touch my body, you need my consent. And in order for me to give you morally transformative consent, I need to know why you want to touch my body. What's that touching going to involve? And so for me, consent is very much about what is it that I need to know in order to decide whether I want to submit to this procedure, intervention. And so there's a little bit of tension between the as I understand it, much to my chagrin, not being my mother's chagrin, not being an attorney, but the reasonable person standard. What would a reasonable person want to know versus like, what would I want to know? What do I want to know in order to decide, yes, this is kind of procedure I want to undergo. And as a person who often asks a lot of questions in the clinic, that can be frustrating sometimes to physicians who are like, wait a minute, I wasn't prepared to explain, like the base rate of false positives or false negatives with some test or something like that. So meeting the informational needs of the patient is important in order for that patient to decide whether they want to submit to healthcare or not. Different patients have different informational needs, and that's part of the challenge because we live in this world where some people are super pro AI. They've like the ecosystem is kind of muddied with hype. And so some people are like, AI is great, like it'll give me great medical care. Other people are like, wait a minute, there's AI in this hospital, and then all ends of the spectrum. So hence the challenge, right?
Yeah. And sometimes I think in the law, especially, we're aiming to kind of standardize that. It's hard to take each patient, each healthcare consumer as they come in and then have sort of a different rule, especially if you were trying to train clinicians to create sort of just a level playing field and make sure that people are informed about their care. So I think one kind of key difference is just that AI is one more thing that might be a little complicated, or it might make it a little harder to meet those informational, and understanding any intervention is kind of the key to informed consent. So there are some frameworks, there are a lot of frameworks out there, and they're kind of in some ways up for grabs. I think bioethicists are seeing things differently and kind of trying to figure things out. Should frameworks for evaluating whether consent is ethically necessary or even ethically preferred be kind of risk-based? Should it depend on the kind of risk or the degree of risk that the AI might pose in someone's care?
I think that might be one component to determining whether informed consent or notification that doesn't require a formal informed consent procedure. I think that there are several factors, and risk is one of them, both in terms of clinical risk of the actual intervention or procedure, but also with the additive risks of using the AI technology. It's important to note, though, that sometimes artificial intelligence also reduces the risk associated, because we tend to think that humans are the gold standard. But as we have found in some research areas, particularly in radiology and others, there may be times where an artificial intelligence tool can actually lower the risk and actually be better than some kind of human intervention. However, we also need to think about several other factors when we think about this, in addition to the concept of risk. One of them is the idea of autonomy. So we think of autonomy often when we're talking about informed consent as patient autonomy in the ethics realm. But here I'm talking about artificial intelligence autonomy. And so when we think about artificial intelligence, one of the goals of AI is to be more human-like and to think and decide more like a human in many ways. And so the way we think about autonomy, and even if we're realizing the full potential of artificial intelligence, is that it might make autonomous decisions if we allow it to. And so I think that the level of AI autonomy needs to be assessed as we think about informed consent. So if a human is making the decision as expected by most patients, then I think we're less likely to need that. However, as we go down the continuum where AI is making decisions or even taking actions, this is at least at this time in this current day, is a need for artificial intelligence to be disclosed at minimum and potentially informed consent to be used. Also, I think that there's also some interesting deviations where AI might be learning absolutely fantastic things. And so we have another criteria we need to think about. And that is the AI actually deviating from the current standard of care? Artificial intelligence is fantastic at taking lots of different information, and there might be new learnings from that type of information and that tool. However, we need to be cautious about the recommendations and how they deviate from the standards of care. We need to make sure that we have good clinical trials and really sound research if we're using such tools within the clinical care environment.
And if they deviate from the standard of care, one would think they might be better. They might deviate from it in a way that is giving a better care. So
exactly. We're actually think that's great because it's actually learning something that is not in the current pathway of medicine, right? And so we're actually asking artificial intelligence in many cases to make these connections. But we think we need to put some limits on that in terms of how far outside of the current scope are they to act without having a structured research or outcome study. And I think the last thing I'll mention is that if the patient is seeing directly, or what we call patient-facing artificial intelligence, I think that's also a time where at the very minimum notification and transparency is needed. But in many cases, we might want some type of maybe informed consent light. In that case, if there's a patient-facing chatbot that's generative AI technology, we might want to make sure that the person has the ability to know that that's not a human, but also has the ability to get more information if they would like to, particularly about the potential risks of misinformation and other things that can come from that technology.
Yeah, so I think it's really important to distinguish things like disclosure. So are you going to let people know that there's ambient listening versus consent? Are you giving people the option to say, here, there's ambient listening. This is what we do with it. Do you consent to it or not? Because it's not genuine consent if you can't say no. So disclosure is telling people this is what's happening. And there may be lots of things that we feel inclined to disclose. And in fact, I suspect risk managers are going to want to over disclose. But I think that's very different from saying you have the right to decline. And if you don't have the option to decline, then consent is meaningless. So that's the first part. And I would say now that also helps us talk about where are we going to be using AI in the healthcare delivery process. So risk, I think, is a little bit like it's relevant so long as the use of AI is already something that we need to get your consent for. Here, let me give you an example. Healthcare administrators, hospitals, hospital facilities are empowered to make decisions about their staffing levels. Staffing levels can affect quality of care on the ward. But we don't say, before you come to this hospital, should we disclose to you our staffing levels and get your consent to be at the hospital? How long the shifts are might also have some implication for the quality of the care that you receive. But do we want to say, did you know this is our staffing level and how long people have been working? Do you consent to be here? And I would say that's probably also an ineffective, like that's not the right thing, because what if patients are like, well, I have no place else to go, so I consent. But you feel like the staffing, the wards are understaffed and the clinicians are working too long. That doesn't then mean, well, the patient's consented, so now all of a sudden it's morally okay. So I think there are these things, there are these aspects of healthcare delivery where what we care about is like, is that sufficiently competent medical care? And I think a lot of people's worries about AI are that the AI is going to confabulate or hallucinate or lie or whatever we're calling it now, where it's going to get something wrong. And then to me, the issue is not, well, did the patient consent to that or not? But like, was the AI sufficiently reliable and did we have sufficiently credible evidence that of its reliability, that its safety and reliability, that we should be using it on patients? And so that's a regulatory issue and less a consent issue. Now, once we say, yes, we think this is, safe to use in a patient-facing basis, then it may be the case that we should get consent from the patient. But if you've got something that's incredibly accurate, such that saying, declining to use it would subject you to a higher risk of not having whatever your medical condition is being detected, then it may not be the sort of thing that we want to give people an option for. That is to say, we'd say, if you want to be screened, then we're going to use AI. If you decline the AI, we're not going to screen you. The only other thing I wanted to add is I think this question about whether the AI is deviating from the standard of care or not. Do we want clinicians to disclose, I gave you the treatment that is what the guidelines recommend, or I gave you the treatment that is what the guidelines recommend, but I deviated from it a little bit because of my own expert judgment. And where now it's like, how much do I trust my clinician? So I think we might be in the same position relative to the AI, but my question there would be, what's the evidence that we have that the AI, that whatever its judgment is, that it's accurate? And if you can show me, yeah, here's the study where it gets it right more often than the clinician, then I think that's going to be very different from just going, I trust this thing. I'm not a big fan of just trusting anything. I think we should ask what the warrant is for thinking that the thing is trustworthy. And that's part of fitting into safe and effective and evidence-based medical practice. So consent can't obviate for that. And then there's a bunch of things where I feel like that's how the health system runs. We're not going to get your consent for it.
Yeah, I think it's important to see what the AI is being used for. And just to unpack a few things you were saying, I think embedded in informed consent is the idea of informed refusal. So we want to give people the information and then they can sometimes take or leave it. That is really a different concept when there are a bunch of choices. They could understand all those choices and pick one. Sometimes they'd be foregoing the care altogether because the AI is just so much embedded in the task. And I do think the FDA has, to some degree, regulatory power over some of these tools, depending what the tool is and what it's being used for. And we usually look at software as a medical device a bit differently from some of the clinical decision support systems that are kind of thrown into other tools. They come up in the electronic health record to a degree, or are just kind of standalone products. And that product environment can be confusing. And some things happen at the point of purchase where a hospital is saying, a large hospital system usually is vetting the product. In the software as a medical device instance, the product has gone through an approval process. You seem to suggest because it's a standard of care, maybe you don't have to tell someone, but I would think maybe because it's a standard of care and what's going to be used, it does make sense to kind of at least disclose it.
So I'd say here's like a couple of examples. If the radiology department, if there's very compelling evidence that using an AI system to make a diagnosis from a radiograph is sufficiently likely to be better than a human making that diagnosis, that the clinicians are like, I wouldn't want to do it. I want to use the AI because I don't think I'm going to do as good of a job. Then I think that's the sort of thing where if you might want to say, do we disclose to patients already how much pre-processing there is in the radiology? Do we disclose to patients whether we're using a Siemens machine or a GE machine, there's a lot of stuff that we don't disclose to them. And especially when you're talking about lab work, which assay we're using, there's a ton of stuff like that. And I think AI in that kind of like back-end lab work, processing of images is probably just not the kind of thing that we tend to disclose anyway. Now, I email my doctor, hey, there's this, side effect, or I'm worried, I'm having this experience, I'm worrying it's a side effect of some medication that I'm taking, and I get a message back. If that wasn't my doctor, but it's signed by my doctor, right? But it's like an AI, then I would feel like, wait a minute, that's the sort of thing that I would want to know. I'd want to know so that like next time I see my doctor, I can be like, thanks for answering my message. And if the doctor was like, what are you talking about? And also because I would want to know, like, was that my doctor's recommendation? So for me, it's very different than if the doctor was like, here, I wrote you a note and then the AI made it more compassionate and pretty, and versus the AI sent me the note. Those are things that I would want to know, but that's because those are things that I'm sort of dealing with very directly.
Yeah, I think also that example is deceptive. If you didn't tell the patient, they would think the doctor wrote the note, and that can be, that's an ethical issue that's even more maybe obvious and extreme. And then you also note the things that maybe in radiology, a human couldn't do anyway. Somebody can't say, oh, now I'm going to breeze through 10 million images to see what trait your image has in common with those. So AI is clearly going to have a good purpose in that. Susannah, what do you think? Do you want to weigh in on that?
I think a couple points. We need to be sure that AI or any tool is not just working more effectively across all people, but also equally works with subgroups of people. So even things like imaging, for example, you might not think that might be differentially effective for groups of people. However, it can be quite simply. And so we really need to think about when we're looking at the overall sort of benefit and risk stratification, we do in some cases need to take into account who it is that we're talking about, because some tools just frankly work better than others for certain types of people. Similar to everything else in medicine we do. We got to know. The other point to make is that we have been focusing on clinical uses of artificial intelligence. And within two organizations that I have stood up AI governesses and run them, one thing that is important to note is that clinical usage of AI is actually the smallest percentage of AI usage within a healthcare system. The largest usage is with operational uses, such as pre-authorization, revenue cycle management, scheduling, a whole bunch of stuff that impacts clinical care, sometimes indirectly, directly, but isn't actually something that clinicians necessarily use to augment or to alter the specific care and treatment of those patients. Additionally, I think this is somewhat moving target, this discussion. And I do wonder in 5 years or 10 years, if we'll look back on this discussion and think, oh gosh, what were we thinking? AI is just, it's just everywhere now. It's just embedded in things. Or maybe we'll say, oh gosh, this hype stuff, this AI was just so overhyped. It's, not really done much at all for us. We don't really know where we're at in terms of that bifurcation, right? However, people, at least empirical research that's been published out there, is that we have to think about the patient voice when we're talking about this. Yanks and I are both ethicists, and all of us, all three of us are ethicists. We're also patients at times, but I think it's important to listen to people who are patients themselves. There have been published articles in the last couple of years looking at patients' perceptions of artificial intelligence and their care. What do they want to know, etc. And I think the bottom line there is that most patients do want to know artificial intelligence usage. They don't necessarily have high degree of trust of AI. There are some that absolutely do. And three, they do have some significant concerns in two different camps. One, is this going to make all this technology and AI make it expensive for me? You talk about all this great fancy news, is that going to impact me? And I don't think this is heard often. Consider is that in a few years, likely we're going to be using many, many, many more technologies. And so when we think about the practicality of notification, informed consent, and others, not only are we going to see us shifting in sort of the acceptance perhaps of these technologies, but also in terms of the emotional and administrative burden that it's going to take to involve patients at any level for this. So I just imagine myself or my family member being in the ICU. Even nowadays, most large medical centers are likely running between 10 and 30 different AI models currently in an ICU. If we're going to say that we're going to notify every patient of every AI and inform consent, this is practically speaking both a significant burden on and their family members. And additionally, the amount of time and effort that it would take would be astronomical in terms of assuming that burden could be lifted by disclosure and informed consent. So I think we always need to take a pragmatic perspective when it comes to both the patient perspective, but also in terms of the...
Yeah, I mean, if I could follow up, I think that last point about, there's this kind of idyllic image of the doctor and the patient sitting down and the doctor explaining things until the patient fully understands. And that's consent. And that then is in stark contrast to what's the clinical reality where consent is often a form. The form is very complex and long. And so the problem is the more things that you ask a patient to consent to, the more difficult it is because now you've got more things to explain, more things to go through, longer time. And so it can detract from, your inclination might be to think getting more consent is always better because I've got a more informed patient who understands more aspects of their care. And in the ideal frictionless plane, that's how it would work. But in the real world, it's likely to be the case that the more things you get consent for, the more there's information overload. And the more that the patient either checks all the boxes or sort of tunes out so I think we have to take these very practical concerns about making sure that we get the consent for the things that the patient can control or that the clinical team can control, where there's also a meaningful choice. And then risk can probably factor in then about which of these are going to be the most momentous, where risk does have some relationship to the patient's values.
Yeah. And then when you take those tools and you look at what patients might want to know, there's also kind of an ongoing discussion about whether patients are really looking to know anything about the algorithm and the data set. And to Susannah's point, kind of how some tools may or may not, they may have left out a subpopulation or not be as appropriate for certain groups of people than others. That I would sort of contextualize as wanting to know the details. And then some might say they just want to know that AI is being used. And then after that point, you could let them ask those questions if they want to know. I do lean, I think, more in favor of informed consent, perhaps than either of you. But I think that that consent fatigue can kind of be avoided by better decisions about which information it is that is really useful to patients.
Yeah, and I think that there's a really important point to be made is that, when we think of informed consent, there are many, we've already talked about this a little bit, but, there are a lot of different judges that come into play. I think I'm, certainly an advocate for very specific use cases as we've discussed. However, one thing that I think is really just good old fashioned, excellent communication discussions with patients to me is one of the pivotal factors in making sure that you have therapeutic alignment with your patient, that they're on board with the general philosophy and scope, and maintaining overall general trust as a clinician with your patient is really the critical factor. And if you're going to use a technology that you think that person might need to know about, even want to know about, that is something that comes from building a relationship and communication. I know that may sound a bit ideal in today's, more transactional and sort of fragmented healthcare system, but this is a skill that can be trained. There's evidence that, emotionally based and empathy based communication skills training produces better outcomes and discussions of artificial intelligence than any other.
Yeah, and I'd want to say it isn't that I'm against informed consent. I think what I would say is it's a really important tool, but like any other tool, if you start to use it outside of the purposes for which it's sort of designed, then you degrade the tool. And so, a central theme of my book, for instance, is that bioethics has become very attuned to issues of consent. And that's really great. But there are issues of justice and fairness as well. And bioethics has really lost its ability to say, what are those issues? They don't necessarily relate to the doctor-patient relationship. They relate to a bunch of other stakeholders like regulators and policymakers and people in the C-suite. And to the extent that those people become invisible to bioethics, then you get a big moral loophole. You get their ability to make decisions without being held accountable by ethicists. And so what I worry about here, like when we talk about what subpopulations do these AI systems work well on, and then where do they not work as well? That's an absolutely fundamental question. There are lots of examples of cases because of the way American healthcare works where Black populations are not as well represented in the data, and AI systems don't necessarily work as well for them. And to me, this is a fundamental issue of justice and equity. But that comes at the point of then deciding which AI systems we deploy and whether they meet the standard of safety and efficacy for all these populations. I'm not sure that the solution to that is to say, you know what we want to do now? We want to take patients that have the least access and that are most marginalized in our healthcare system, and then try to go through a conversation where we explain to them, that they may be underrepresented in training sets. And so this AI may be less accurate for them. Do they want to consent to use it? I would like us to pay more attention to the problem upstream so that we eliminate having to have conversations like that. Having said that, I can see where if I was a patient who had to go in now, where I might be like, I'm actually concerned about whether some of these AI systems are going to work equally well on patients like me. And I might want to ask those questions. But I think it's very different to say a patient who wants to ask those questions should be able to get answers versus saying, if an AI system is used, then we need to mandate that conversation happens with every patient. Because now I'm just worried a little bit that something that should go on in the regulatory sphere, we're substituting, consent with the patient. Because my view is if something isn't sufficiently safe and effective that it ought to be used, then it ought not to be used. And the fact that a patient consents to it doesn't transform its use into something that's morally permissible.
The New York City Bar Association is a dynamic community of over 23,000 legal practitioners. Members shape the future of the legal profession, serve the public, and gain an edge in their careers. To learn more about becoming a member of the City Bar or to join today, visit nycbar.org/join. Save 20% on semi-annual dues when you join. Call Customer Relations at 212-382-6663 and use code POD24.
I think the question then is whether there's some relationship between informed consent and regulatory failure and what that relationship is. If AI weren't vetted at various stages by regulatory agencies and purchasers, then does informed consent offer protection? To me, it seems a lot better than nothing, even if it's inadequate on its own. I don't think it would make something morally impermissible permissible necessarily in these cases. It would really just call attention to the use of AI and its risks about which the consumer might be unaware. So to me, the same situation of poor vetting without informed consent would really be worse, not better. You seem to have a concern about whether informed consent could somehow undermine safety or disincentivize vetting that should happen upstream. I'm not sure it does that. I don't think an unsafe tool should be deployed and then kind of dumped on the patient who's left to vet it and agree to it. I think that's your concern as well. But I would say that's not how things are now. Most importantly, I think arguments about informed consent's inadequacy as a singular consumer protection measure don't support the suggestion that informed consent's not important or that the consumer need not know that AI is being used or how it works or basic information about it, even if the product has been carefully vetted.
Well, healthcare systems right now are just learning and just equipping themselves with the knowledge and capabilities to accurately determine whether certain AI tools are effective and safe within their walls. Many large academic medical centers have more resources than others. But there are many organizations in the United States that do not have an AI expert. They don't have an AI governance system. And we really need to think about how we can construct a system that works for all healthcare providers, not just the ones that have the fantastic AI capabilities and people who are AI randomized control scientists and things like this, right? So this is a sort of a meta issue of justice, not only in terms of patients themselves, but also in terms of the ability of healthcare systems to differentially vet certain technologies within systems.
I think those are really important points, that there's a big difference between what large academic medical centers are able to do in terms of developing their own tools, vetting tools that are being marketed to them, versus smaller institutions that are going to procure tools. And then I'm a little bit less sanguine about whether the quality of the tools that are available has adequate evidence behind them. I think we have a little bit more work to do about ensuring that AI systems are validated in ways that properly control for confounding and real world differences that aren't going to show up in your training data. And to some degree, this is a difference between the type of evidence that we require for a drug, the type of evidence we require for a device, and then the type of evidence that we require for an AI system. And I think that's an important conversation to have. And I fully agree. And that is a question about like regulation and its adequacy. I think it's relevant to this conversation because when we talk about whether people trust AI and when people come in and they're worried about AI, my sense is these are the things that they're worried about, right? They're worried, like, is this thing going to work? And, to some degree, I would share their concerns. And I think at a system level, what I would say is the proper response to that is we need to ensure adequate warrant for the use of those tools, right? From a bioethics standpoint, I think focusing on those sort of regulatory issues has the beneficial effect of holding important stakeholders' feet to the fire so that consent, when it comes up, is the relevant issue, right? And that we don't wind up trying to turn every problem into a problem of consent. And that's why I also think, just as a side note, that like liability and lawsuits are going to play an important role in incentivizing a higher degree of evidence about safety and efficacy, because you have, in our system, you've got two places where this pressure can come from: the upfront gatekeeping role that FDA plays about access to the market, conditional on high bar of safety and efficacy, and then post-approval, are there harms that you can demonstrate from the use of your system? It's just, I bet, quite a challenge to demonstrate harms from the use of AI systems that might be problematic in some way.
Yeah, and some of that is it might eventually fall into a product's liability situation where someone is selling a product, they're not really quite sure how it's going to play out in a hospital system's population. I think another issue along those lines is what happens when the purchaser, the hospital system, just uses the AI for something it's not at all designed for. I think that's a big issue, that, it's kind of like off-label drug use, that the thing comes in and then suddenly someone says, I want it for this. There's kind of a right to try issue. Or doctors just say, oh, if it was good for that, it's probably good for this. Once it's in the hospital system, is there a way to kind of control its use?
So I think with this, we have to think about a couple of different factors. When we're thinking particularly about artificial intelligence that continues to learn after it's been implemented, it's a very interesting conception of, whether the product you put into the system is the product that is actually being used right now and with this patient at this, 2 months later. That's a subtle question, but also where in the hospital system a certain tool is being used. There are two factors that I think could help with this. One of them is developing a monitoring algorithmovigilance platform. So one of the things we have created here at Vanderbilt University Medical Center is a program called VAMOS, which is the Vigilant AI Monitoring and Operation System. And what that does is create both a automatic way using IT systems and a human system to monitor what AI is being used. Is it experiencing model drift? Is it differentially working better for different populations? And developing a workflow that actually can make actions on that bit of information. Right now, most hospital systems do not have this capability. So this is something that I think is really critical in terms of monitoring and knowing where tools are being used. Additionally, we need to think about how patients interact with systems, because again, we're thinking about how maybe a semi-autonomous entity is interacting with their care. And many times we're solving problems that are not necessarily solving problems that either clinicians need or patients need. And so as we move forward, we also need to design these systems that prevent that usage. So, hey, oh gosh, I have this tool that I heard about. It's a prediction for end-stage kidney disease, that's for ICU patients, but I need a tool over here in primary care. Let's use that one, right? The better solution is to make sure that we are developing the tools that the clinicians and the patients actually need where they're at, so they don't have to use sort of, ad hoc trying to think that they can use these other systems. And I think one more point, and I'll end here, is that we're talking about informed consent as if physicians and clinicians know enough about these products to provide that information. And while I don't like to make the analogy to medications, there is some analogy to be made, right? Many clinicians know, from their clinical experience or from their trials that certain drugs work. But to ask them about the actual mechanisms of that, they might have some loose idea, but some drugs we still don't even know how they work. We just know that they do, right? And so that's one way with artificial intelligence. Clinicians might not be the best people to do this. And so I think there's been a call. So, for example, I co-lead with patients and with one of my colleagues at Vanderbilt University Medical Center, the AI Patient and Family Advisory Group. And they're very involved in how we can actually conceptualize these issues from a very big organizational standpoint and incorporating their perspectives and both what their needs are, what we can start designing, using them out the entire process, has been a really critical point in making sure that we're aligning the tools with the actual uses and the use cases.
I was just going to say, I fully agree. Very few people. So lots of things that work where we don't know the mechanism. Aspirin we know is an analgesic. We didn't know the mechanism for 100 years. But I think this is where it comes down to exactly what is it that we're supposed to disclose to patients. And, the patient often doesn't need to know our hypothesis about the mechanism, which is often wrong, by the way. But they just need to know, what evidence do we have that this is actually works? And so the good thing about clinical trials, they don't tell you the mechanism, but they can tell you, yeah, for patients like this works or not. And they can also identify what are the side effects. And I think that these, one of the important things about drugs is they have a label that has indications on them. Those indications and the labels are often overly broad, but AI needs exactly that because most AI systems are still incredibly brittle. But we've got large language models that people talk about as though they're general purpose systems. And so I do very much worry about system trained and validated in one use case, then being used for something that seems similar, but where now there's no guarantee that we've got the same type of performance from the system. And I think, these algorithmic vigilance is a great idea. And, we have genetic counseling for people who want to understand their, not just facts about them, but how those were ascertained. And so it's interesting to think about whether, if this continues into the future, whether there's going to have to be something similar that would help people understand the nature of the way certain automated parts of their care are being delivered and what their options are and what they need to do in order to maintain safe and effective care with these automated tools, should those appear on the horizon.
Yeah, I think one issue that comes up with that is a lot of people are quite prejudiced against the tools that are the least explainable, but some of the tools that are the least explainable, the black box algorithms, might turn out to be the most helpful. And I think in many ways that would be a better case for needing informed consent and for needing to say to the patient, we don't understand quite how this tool came to this, but we think this drug will work for you. And in that situation, I think it's a good reminder that not every doctor can explain every mechanism of every drug, and maybe in some ways is analogous to that. There certainly is danger about explainability. It's kind of the same issue to pull it back to informed consent. If you were to say it's not explainable, but you consent, so it's all fine, we probably need to look into those models more carefully at some regulatory level.
We tend to think in sort of bifurcated terms currently, in today's day and age, in terms of AI, just loosely. We kind of think of predictive algorithms that are being put into the clinical care. We also think about large language models, which are their own kind of predictions, but we tend to think of them a little differently. And monitoring large language models, sort of AI, is also a unique technical challenge. Currently, there really are no tools, to my knowledge, that can monitor the accuracy and safety of large language models. And in fact, one of the research studies that I lead at Vanderbilt Center is funded by ARPA-H, is the Vanderbilt Chatbot Accuracy and Reliability Evaluation System, what we call VCARES. And in our work, we are finding that even with the current state-of-the-art generative AI, it's still making significant amounts of errors, and some of them are quite serious. And we need to be able to integrate independent evaluation systems in the development of large language models to ensure that they are saying the right things to people, giving the right advice, and also frankly something that is actually quite harmful to individuals. And the use of large language models is getting quite extensive in many areas. And we need to be extremely careful about the deployment of these technologies in particular.
Yeah, I think we also should be really conscientious about how many healthcare consumers don't want to talk to a chatbot. They don't want to ask their medical question. They're developing this relationship of trust with their doctor. They don't want the chatbot. And I think AI tends to, have some administrative efficiencies, but I'm not sure that the administrative efficiency is always beneficial.
And I might push back on that one. There's some old fantastic studies that have been done with various avatars and also current studies, particularly in mental health. And as I don't know if I mentioned that I was a mental health provider at Memorial Sloan Kettering Cancer Center for almost a decade. And so as I think about how these tools might be used, we have to really think about the systems in which they're being constructed, but also, again, that end user and patients, because some patients prefer by a long shot to talk to a non-human. And I think that you were seeing this in the media, we're seeing it with movies. So to assume that a human is preferred is a big assumption. And number two, to prefer that even when it's not preferred in the beginning, that the non-humans can absolutely engage in ways that perhaps at scale, humans may not even be able to do. And I think that that is one thing we have to think about, not just in terms of operational efficiency, but also in terms of delivering empathy at scale within what I call, and I've historically called, sort of organizational empathy. We have clinicians, but we also need people to be able to engage with the healthcare system in a way that their needs, when they need it, and at the right time and in the right ways. And there are some unique factors with various types of AI that they might be able to adjust different education levels, different languages, different abilities, and informational needs and preferences in ways that we really can't personalize to the extent that we human interact.
And that's very true, especially because many people, before they go to see their clinician, are using a language model to find out about their test results, or if they're newly diagnosed, to learn about their disease. So people used to talk about Dr. Google, and so increasingly it would be, Dr. LLM. Lots of people that I know do this, but everybody I know who does this has a funny story. So far, they're all just funny about the misinformation that they've received, as well as some of the really important information that they've received. And so you do get these very complicated now relationships where the doctor and interacting with the patient is partly verify what they've learned through their model that they've interacted with and clarify the misconceptions that they've learned through the model they've interacted with. But I think standing up above this a little bit, right, rising up above this, I think there's two issues here. One is something like some people may only want to talk to a human. Some people may have preferences for machines and under certain circumstances or not. But question about, do people know and what should they know? And, I think automated, especially because, so I'm not a big fan of like automated patient response systems, automated anything that would respond to the patient, mostly because I think we don't want errors to get out. And so they need to be looked at by clinicians. And I think there's just a genuine scientific empirical question. Are things better if it's generated by a model and it's reviewed by a clinician? Like, do we save any time? Some studies say no. And is it better if the clinician is the one who looks through the chart and writes the email? To me, I'm a philosopher. That isn't an armchair question. That's an empirical question. And so I worry a little bit about people who have very strong commitments that one must be better than the other, especially once the science comes out and seems to contradict some of what we've seen there. But to me, this all fits under the umbrella of making evidence-based, data-driven health systems, rather than having AI come in and just push resources in different directions so that now we're spending a lot of money over here as opposed to over here, but we're not really sure that we're getting sufficient bang for our buck to justify those choices.
Yeah, I think we also, when you're kind of talking about how patients educate themselves, and I think it's been a very quick trajectory from the time when patients had to ask permission to go in the medical library and look at the books on paper to having search engines at their fingertips. So I think patients come in very highly educated now and can really read the full medical study or ask for drugs by name, that kind of thing. A lot of asking for drugs by name has more to do with advertising. But traditional search engines have really empowered patients so significantly. And it seems to me the LLM are maybe just muddying the water for people, that they're providing sort of a shortcut and a summary, but maybe certain traditional tools that are still computerized but are not the newest type of AI are still pretty beneficial to patients.
Well, so I go between having and great concern. One thing you mentioned, Anne, is that search engines and access to internet have provided patients more information. And I want to be really specific that we have a big digital divide in our country and also in the world. And so I think that informational justice has been very much realized by certain groups of people over others. And that is a concern perhaps with various technologies such as artificial intelligence, because they might require higher speed internet and good cell service and things like this that may increase that divide. That being said, artificial intelligence and such as ones that you can just access for free or that are already available automatically through many search engines can be helpful because it can summarize vast amounts of information that do put it in pretty bite-sized bits for people to understand. And so I think that if we can, and a big if we can rely on them, and we cannot yet, to provide accurate and reliable information, but they're pretty good. And if you can get a nice summary and then you do have the resources and the ability to verify, then even more fantastic. So I do think you have to think about who the person is that we're talking about and how these technologies may empower some groups of people, but also may disempower others.
Yeah, that justice question really remains an open question as people kind of try to bridge that digital divide. When we talk about informed consent, I think patients and healthcare consumers are not realizing that sometimes people in that medical ecosystem, whether they are residents and fellows and doctor practitioners in general, are using LLMs themselves to summarize some of the large-scale research papers that we as patients expect the doctors to have read. And I think there's an efficiency there, but there's still a lot of room for error. And it's another opportunity for informed consent, or at least for transparency. I would want to know if the doctor has looked at a summary or looked at the actual research paper, but I'm not sure patients have much access to figuring that out.
So I think that's an interesting example about what might a reasonable person want to know versus what might you want to know. And I think having a conversation, so when you just gave me this information, did you read the research or did you have it summarized for you by a bot? And then did you check up on the bot? Like, I'm not opposed to having those conversations with clinicians, but I think it's very different than to have a clinician come in and say, all right, I'm making this recommendation, and whether I read all the research in detail, whether I looked at the abstracts, whether I had a model summarize it for me, because I think some of these questions are about what is within the scope of competent medical care. To me, it's sort of like that part I would care about, that if a clinician was actually not reading the papers and in that sense was not, in a certain sense, doing their due diligence, then I would worry about the competency of the care that's being provided. Whether there are ways of using these models that are consistent with the practice of competent medical care, that's what I'm not sure of. And so I think disclosing things to patients where there's no clear signal also doesn't do any good. Because what am I supposed to do with it? If you're like, we want you to know that this is our treatment recommendation. We want you also to know that we used AI in the course of this. So what's that supposed to do for me? It's supposed to drive my confidence up, drive my confidence down? Like, how did you use it? So disentangling the issues so that we can bin them properly into like, was the conduct part of like acceptable medical practice? Yes or no? And then how much should we disclose to the patient to either reassure them or tell them, hey, we're going out on a limb here. Are you willing to go with us on this thing like off-label medical practice or things like that?
So Alex, based on what you're just saying, wouldn't informed consent then just be one more guardrail for patients? Wouldn't it be just one more thing that can be tacked on to that kind of already vetted, already perhaps regulated AI tool that comes to them in the healthcare system?
I mean, ideally, informed consent serves a bunch of purposes. Part of it is so I understand what's happening to me and I understand what the care team wants to do for me and I consent to it. And so we're also trying to minimize regret in a certain sense that nothing in medicine is 100% certain. Even if something is 70%, you're 70% likely to benefit from this treatment. That means, well, you might not actually benefit from it. And so for people to understand, I'm going in, I'm going to get this care. It might not work. And if it doesn't work at the end of the day, they go, okay, I still made the right decision. To me, a lot of informed consent is about making sure that patients understand so that if things work out, great. And if they don't work out, they can still say, well, I acted according to my values, given the best information that I had. And if patients can protect themselves from AI that's patient-facing and so on, that's great. And if it doesn't detract from our ability to hold C-suite people, corporations, developers, vendors, feet to the fire to make sure that they're making a profit by adding real value, safe and effective interventions, then I think, yeah, it's great. Assure those things and a regime that has informed consent for the right things, titrate it down, that we're not sitting here for half an hour talking about every AI system that we use.
Sure. Susannah, do you have any last comments to add?
I think that it is a really critical area for ethicists, legal scholars, lawyers, healthcare leaders, and patients and their family members to really continue having in-depth dialogue and discussion over the appropriate use of AI within healthcare. I think that there is a very big push to use certain technologies quickly, but we also need to make sure that we're solving the right problems and that we include the patient voice, and that this is much broader and bigger than merely informed consent, because it's such a small use. I think my argument goes even wider, that we really need to really thoughtfully engage our patients and their family members.
Great. Thank you. Thank you both for being here today. Again, our guests today were Susannah Rose and Alex John Lunton. Thanks very much.
Thanks for having us.
Thank you for listening to this episode of the New York City Bar Association podcast. Opinions expressed are those of the speakers and not necessarily of the City Bar. If you enjoyed this podcast, please like and subscribe wherever you listen. Find more City Bar podcasts on Apple, Spotify, YouTube Music, iHeart, or at our website at www.nycbar.org/podcasts. Be sure to check out This Lawyer's Life, a professional development podcast where we talk with lawyers about seizing opportunities, learning lessons the hard way, and about what makes them tick. And don't miss Building Belonging, a podcast that embraces authentic conversations about DEIB solutions by amplifying the most marginalized voices in the legal industry and exploring spaces others dare not. This podcast was produced and edited by Jalen Martin.